And we talked a lot about prevention, and I think this is, as an orthopedic surgeon, we think about ankle fracture. Someone mentioned an ankle fracture. We fix ankles and we think it's over. We give pain medication and life goes on, but it doesn't for a lot of our patients. We get patients addicted. Doctors, surgeons, we are the opioid, the pill providers in many ways. I'll give you an example. When I was a resident many years ago, I was actually punished by one of my surgeons for not giving enough pain medication to a patient that had surgery, because they were called on a weekend, said, hey, I'm in pain, doc, I need more medication. So, the whole paradigm of how we treat this, how we approach surgery, how we approach opioid has changed drastically since when I was a resident and now that I'm in practice. So the topic that I have is what we do as surgeons now, what options there are besides opioid. It's not just opioid sparing, it's opioid free. And there is that type of surgery. It's available in St. Luke's, it's available in Orange County, and that's what we're going to talk about today. And it's about resources, that these are resources that, Ms. Miller mentioned that you may not be aware, but we have that at St. Luke's. So a little bit about me, these are my disclosures. Where I trained, I grew up in Queens, went to high school in the Bronx. I'm from Long Island. I did my residency at North Shore. My wife did her residency at Northwell, at Mineola, Winthrop. And I went to the Houston Clinic in Columbus, Georgia, where I did my residency fellowship in sports and joint replacement. When we came back, I was part of orthopedic sports medicine in New Windsor. And recently, are part of now Crystal Run. So orthopedic surgery, I do sports and joint replacements. And that's important because in joint replacements and sports, and the three biggest surgeries that cause pain are knee replacements, hip replacements, and shoulder scopes. Are three things that we do that get people addicted. We fix them, but do we really fix them? How do we fix them correctly? So things that we also do is trauma, fractures that happen, and I'm part of committees that look at Orthopedic Institute and also the trauma. Impact of opioids on surgical patients. So, a lot of stats here, and it really doesn't project well, so I'm going to read this out for you. 90% of patients are concerned about opioids, especially now, post-surgically. And they don't always mention that. And that's something we'll talk about more, how you as patients, how people, we have to be talking to our surgeons and doctors about opioids, really starting that conversation. 79% of patients prefer a non-opioid solution. Patients don't want opioid as their mainstay for post-operative pain. More and more, I've noticed in the last year, patients say, I don't want pain medication. And I have to say, listen, you'll be in pain. Are you sure you don't want pain medication? And they say, absolutely. And that's been a big surprise on my end. 7% of patients that are prescribed pain opioids become long-term users. And that's a stat, 7%. And 4 out of 5 new heroin users start off on opioids, on pills. And these pills are given by providers. So prevention of getting these pills not on the streets, not into patients' hands, is really, I think, one of the pillars and is the key to really attacking this in the 5-pronged approach. And this is very important. This little graph kind of shows from 1998 to 2014, and it's probably going even higher now, how the opioid pill prescriptions have gone up, and with that, the heroin use has gone up also. And that's a trend that we have seen for many years now. Impact of opioids on surgical patients, again, as an orthopedic surgeon, total knee replacements, rotator cuff, and hip replacements. These patients are newly persistent opioid users. One thing that I tell all my patients is, just because you're having a knee and hip replacement or shoulder replacement doesn't mean you'll be pain-free forever. Pain is part of the surgery. It'll be a different type of pain. It's pain that we'll have different ways of dealing with it, but you won't get narcotics forever. There is an end game to the narcotics, and that's something we'll talk about, how I've kind of changed the way I deal with narcotics post-surgically. There's about 3.3 billion pills that are unused, that are prescribed. So what happens to these pills? They end up in a medicine cabinet. Kids get into it. They start using it. Next thing you know, there's a story I read on ESPN on 30 for 30 about a retired NFL player who addicted to narcotics after getting hurt, ankle sprains and such. And he would go to different families' houses. And at the lowest point, he would literally go up to people he hasn't met in a long time and raid their medicine cabinets. So these are pills that are in the market. We have to do something for it. And a statistic of 10% reduction, which is not much to do, just reducing it by 10% would not only save people's lives, but also save about $830 million on drug costs, which impacts the pharmaceutical and the insurance side of things. Economic impact, prescription-related deaths is one of the leading preventable health crises. And I think that's the word, it's preventable. And this is, preventable public health problems, and if we can prevent this, we can really get on top of this. It affects activities of daily living, it decreases readmissions to hospitals, and it saves the health industry money, and economically, $50 billion economic burden in the U.S. economy. We talked about different groups that are chiming in saying, hey, we have to do something. First is the AAOS, it's the Academy of Orthopedic Surgeons, saying as orthopedic surgeons, we are causing pain, we deal with pain, we find a different way of dealing with pain. So they have already come out and said this. American College of Surgeons, general surgeons, orthopedic surgeons, bariatric, urological surgeons, they're all saying that you can't just freely give narcotics anymore. There has to be a change. And the Joint Commission, they're looking at all of this to see how as surgeons we're dealing with pain. Patients have indicated that they don't want narcotics, and we talked about this. 57% post-surgically don't want opioid medications, and 30% of patients have fear. They're nervous about taking opioids long-term. So, it's a multimodal approach. You can't really do this in one way. There has to be different ways we attack pain after the surgery, because if not, then you can't deal with the surgery. It's hard to recover from surgery, and we want a positive outcome. And we'll talk about the different ways for different surgeries that we can do this. So it really comes in three phases. First is preoperative. What can we do before the surgery to kind of help with the pain before the pain comes? Then it's intraoperatively. What can we do during the surgery to help you with pain? And the last part is post-operative. What can we do besides opioids that can help you with pain after? And if we can do a little bit in each of these stages, then the end result will be you'll be using less opioids post-surgery. So what does this all mean? So for knee and hip replacements, we do a thing called spinal anesthesia. I had a lot of my patients say, hey, listen, I don't want to be awake during my surgery. I don't want to know anything. So when surgery, there's about two ways that we do it for knee and hip. It's a needle in your back, your legs go to sleep, we give you a little sedation, you go to sleep. It's great for several things. Number one, no pain during surgery. No pain after surgery. It lasts up to 12 hours. And we know after surgery that the first 72 hours, if we can keep you from getting that big pain hit, likelihood of you using pain medication after goes down drastically. Blocks. And these are the spinal blocks that we do for certain surgeries. For shoulders, before anyone who has a rotator cuff surgery, we put a needle into the shoulder by anesthesia that puts your arms to sleep. So after surgery, when you wake up, you have no pain. So when you go home, you're comfortable. Same for knee replacements and anti-inflammatories. Anti-inflammatories sometimes get a bad rep. Some people say, I can't take ibuprofen, it makes my stomach upset. You take it with food, and most of the time it's okay. We use anti-inflammatories, we use muscle relaxants, we use steroids before and during surgery to help you with pain. Local injections, I think this is the two that I really want to talk to you about and really focus down on, is a thing called Lidocaine. You go to your dentist, he gives you a little numbing medication, it numbs it up, and by the time you get home, the numbing medication is out, and you're in pain. What if there was a medication you could use that works for the next 96 hours, where you don't have pain at the same level for 96 hours, we get you over that 3-day danger zone, the chances of you using narcotics goes down drastically. I'm sorry if I'm blocking people. I'm walking around. So it's a medication, and we're talking to some of my friends here who have had the opportunity to get to know that I've been using this medication Exparel at St. Luke's, and we've had this at St. Luke's for several years now. It's a long-lasting bupivacaine that lasts for 96 hours. And what we have seen with this medication is 78% less opioids are consumed during the first 48 to 72 hours than just normal bupivacaine or lidocaine. So that means after surgery, you're using 78% less opioids. So, the natural thought is, okay, you're using less opioids, that must mean you must have more pain after the surgery. I'll show you that actually, no. You're using less pain medication, you actually have less pain after surgery. 10% of patients were opioid-free for the first 3 days. And that's knee replacements, hip replacements, shoulder replacements, ACL, and rotator cuff. That means 10% of patients didn't touch one Percocet, OxyContin, oxycodone, or any of those variants. And again, if we could cut down by 10%, we went over what a big impact that can have on our patients and on our healthcare. Reducing pain. So 78% decreased pain consumption and 13% lower pain scores. So patients that took less pain medication had less pain after the surgery, after the 72 hours. So again, it's a medication that has to be available at the hospital, and we're lucky at St. Luke that we have it available. It has to be used correctly, and I'll show you how it's used. And as patients, you should see and seek doctors and physicians that are providing opioid-sparing and opioid-free surgery for you and your family. So this is just an example of a shoulder replacement. Again, it's injecting all around the area of the surgery. Takes an extra 5 minutes, but I tell you, it's probably, since I've been using it in January, we've cut down our length of stay at the hospital because patients are in less pain. We recently had a knee replacement on Tuesday. They left on a Wednesday. That means the next day. No longer do they have to stay 4 or 5 days, go to rehab, and get, they literally get moving right away. Our therapists notice a difference post-surgically. Our therapists asking, what are we doing differently? And really, implants are the same, the approach is the same, it's just the medication. And I'll get into one more thing that's the same, is different, is the conversation with the patient pre-operatively. And that's also very important. This is a rotator cuff, again. Even those 3 little holes around the shoulder, a rotator cuff is probably one of the most painful surgeries that we do in orthopedics. ACL. So, and this is important. There's certain age population that I really am hyper aware of pain. Adolescent kids, they're having ACL fractures or shoulder surgery. These are the patients that they get a taste of it, and then they go back to college, they go back to high school, and they're looking for it. If you can get them through the first 5-6 days without it, tell them they don't need it. And you tell them they don't need it, they won't ask for it. If you tell them they will need it, they will look for it. And then you replace it. So in conclusion, expectations. More and more in the last year to 2 years, I'm having a conversation about expectations for pain. I say this is not a pain-free surgery. Nothing will be. If your expectations are that you will be pain-free right after the surgery, you will be disappointed. So having a correct expectation with your patient is key, and you should have that with any physician that you see. A multimodal pain approach. It just can't be pills. It has to be a block before the surgery, anti-inflammatory during surgery, injection during surgery, and post-surgery, maybe a muscle relaxant. There's different things that we can do. Communication with primary care physicians and other physicians. If I see a patient that's kind of going down the slippery slope, I call the primary and say, hey, listen, this is what I'm seeing. What are you seeing? As an orthopedic surgeon, I don't see the whole picture sometimes of the patient. We see a knee or a shoulder, not always, but it's good to communicate with other providers. And opioid-free and opioid-sparing surgery is available. You just have to seek it. You look for it, expect it, and that's what I would do if this was my family. And do your research. You've got to look around. My challenge is what I find the hardest is discussion about post-operative pain. Patients are not always upfront with their the use of narcotics. Not just narcotics, even alcohol. I can't tell you how many patients I've had. I say, hey, listen, are you drinking? Do you drink? You can go into DTs after surgery. They say no. and then post-operatively, they go into DTs, and it's a scary situation. So be honest with your physician, because they want the best for you. Sometimes it's easier to give narcotics than expect those phone calls. And I told you about my story when I was a resident. But more and more of us are giving less, and we deal with the call when we get it. And new approaches, and I'm really excited, and we're looking into this pretty closely, is cold laser. Laser therapy before and after surgery for pain has shown to improve pain by almost 50%. So this is something that is up and coming, is a cold laser. And that's it. Thank you.